Dear my colleagues from all over the world, good morning, good afternoon, and good evening for all of you. This is Unal from Turkey. I'm professor in anesthesiology and intensive care at Ankara Medical Faculty. I am also vice president of Turkish Society of Intensive Care and ambassador of Global Sepsis Alliance. Welcome to the World Sepsis Congress Spotlight, Maternal and Neonatal side of the sepsis, one of the GSA's worldwide invaluable and annual web meetings. This is fourth and last session of the web meeting. It's a very big pleasure for me to chair the session and to be together with world's leading sepsis masters. Session will take approximately 2 hours, and 8 very important and well-known speakers will attend to the session. 12 minutes speaking time and 3 minutes discussion period have been assigned for each speaker. During presentation, you may write down your questions online about actual speeches. Please do not add too much interpretations to your questions and prefer to write down short but precise questions. Please do not forget to write down your name, profession, area of specialization, and your country at the end of the questions. After each speech, I will try to ask your question as long as time is permitted. At the end of the session, after 8 speakers, we will have some additional time for discussion, and at that time, all speakers will answer rest of your previous and new questions in addition to their comments on other subjects. So, now let me to introduce you first speaker. It's really a big pleasure for me to introduce you a very well-known speaker as the first speaker, Mitchell Levy. Mitchell Levy from United States, from Warren Alpert Medical School of Brown University, is Chief of Division of Critical Care, Pulmonary and Sleep Medicine. He is also Medical Director of Medical Intensive Care Unit at Rhode Island Hospital. Dr. Levy is a founding member and member of the Executive Committee of the Surviving Sepsis Campaign. He is past president of Society of Critical Care Medicine, and he continues to serve as the representative to the National Quality Forum for Society of Critical Care Medicine. Heading of his speech is the impact of governmental regulations on sepsis outcomes in New York State. Okay, Michel, it's your turn.
Thank you, Nick Metten. And I really appreciate being able to be on this really important day where globally we can all discuss the importance of identifying sepsis early and treating it adequately. What I'd like to do for the next 12 minutes is talk to you about what I think is a very exciting initiative that occurred in the United States over the past 2 years, and that is the first public mandated program by a state government in the United States, and that is occurred in New York State. This occurred because of the unfortunate and tragic death of this young man, Rory Staunton. Rory Staunton died in 2012 from an unrecognized group A beta hemolytic strep infection that he received during a sports injury that was missed in one of the hospitals in New York City. And that gave rise to in the fact that in October 2012, the New York State Health Commissioner announced his intention at the direction of the governor of New York State to require reporting of sepsis performance measures statewide. The performance measures that were used were in fact the Surviving Sepsis Campaign, sepsis measures that were adopted by the National Quality Forum, and they're referred to as the 0500 measures. And at that time, the state mandated protocols be submitted by every hospital in New York State. And the protocol requirements were a system for screening and early recognition of patients with sepsis, severe sepsis and septic shock that involved criteria for those who are appropriate for and those who should be excluded from these protocols for severe sepsis and septic shock. In addition, there were guidelines for hemodynamic support, including where appropriate vasoactive agents with explicit physiologic and biomarkers, including lactate. The methods for invasive and non-invasive hemodynamic monitoring treatment goals were left to individual hospitals based on a table of choices that were available to all the hospitals in New York State. In addition, the hospitals were mandated via these performance measures to administer antibiotics within 1 hour and to complete fluid administration of 30 cc's per kilogram as per standard of care in patients who were hypotensive or who had elevated lactates within 3 hours of identification of these patients. And finally, there was a procedure in these protocols for the identification of an infectious source and adequate source control. So what I'd like to do is go over the data that we collected over this time period. It was a 2-year initiative that is, by the way, still ongoing. And the database from which I'm going to show you the data analysis has over 100,000 patients. And as I mentioned before, it was the first mandated public reporting program in sepsis, which is now, of course, done on a national level in the United States through the Centers for Medicare and Medicaid Services. What I'm going to show you are 2 reports, one of which has been published in the New England Journal and the other which is now under review and with a submitted revision in the Annals of Internal Medicine that looks at hospital performance in terms of compliance with the sepsis performance measures and reports of the risk-adjusted mortality. So, in terms of overall results, this is an example of the report card that each hospital in New York State receives, and you see here the hospitals are grouped according to the percentile of performance that is benchmarked against each other, and so hospitals get a report card that allows them to assess where their hospital is in their performance on the 3 and the 6-hour bundles compared to the other hospitals in New York State, and you can see the 25th and 75th percentile that are benchmarked here. Here is the overall report that is included in this paper that is being now in revision in the Annals of Internal Medicine. And you can see here that over the 2-year period of the trial, the increase in both the 3-hour bundle and the 6-hour bundle, and as I mentioned, this is in almost 100,000 patients, and you can see in these 74,000 patients that were analyzed in this table, an increase in the 3 and 6-hour bundle that was statistically significant over the 2-year period, and with an increase in compliance of 0.43% per month that was statistically significant at a p-value of less than 0.001, while the risk-adjusted mortality decreased by 0.17% per month, and that was also statistically significant over the course of the 2-year period. This is also an important slide because it shows you the difference in patients for whom the protocols were initiated and those for whom they were not initiated. And you see here a statistically significant difference that in mortality over the course of the 2-year period. And for the patients for whom no protocol was initiated, there was no change in mortality, while for the 74,000 patients in whom a protocol was initiated, in fact, you can see here, starting in quarters 1 and 2, a statistically significant separation in mortality between these 2 groups that demonstrates that the patients in whom a protocol was initiated had a significant decrease in mortality over the remaining course of the study compared to the patients in whom a protocol was not initiated. That's pretty compelling data that shows an association between mortality and the protocol initiation over the course of the 2-year period. This is also an important slide because it shows the relationship between risk-adjusted mortality and compliance over the 2-year period. And what you see here is 4 quartiles of compliance with the 3-hour bundle and the associated risk-adjusted mortality that is associated with each of these quartiles. And you can see here in the first quartile, the second, the third, and the fourth, as compliance goes up with bundles, with the 3-hour bundles and the 6-hour bundles, the risk-adjusted mortality declines from 29.8% in the first quartile to 23.5% in the fourth quartile, and that's statistically significant at a p-value of less than 0.001. So very nice evidence of the association with compliance and risk-adjusted mortality that demonstrates as mortality goes up, as compliance goes up across the 4 quartiles of increasing compliance, the mortality associated with those quartiles goes down in a statistically significant fashion. Really compelling evidence that compliance with the performance measures are associated with improved survival in these patients. The next thing, this is another slide that shows nicely that for every 10% increase in the 3-hour bundle compliance, there's a 5% decrease in the odds ratio of mortality at, again, statistically significant at the p-value of less than 0.001. The next data shows us the relationship between time to treatment and risk-adjusted mortality. These are data that we recently published in the New England Journal in May of this year, and you see in the right panel that as the time to compliance with the overall 3-hour bundle goes up, there's a statistically significant increase in the risk-adjusted mortality rate for every hour delay in the completion of the 3-hour bundle. This is also true for the administration for antibiotics. That is, that for every hour delay in the administration of antibiotics, as the same as the 3-hour bundle completion, there's a statistically significant increase in the administration of antibiotics. This was not, however, true for fluid administration. So in summary, what I tried to demonstrate over these last 10 minutes is that the government, we are now in the United States, have significant government-mandated reporting, both at a statewide level, and the data I showed you was for New York State, and there are plans to roll this out in other states as well, and a federally mandated government mandate for compliance and public reporting of performance measures with sepsis. And I think we have to say from the data that I just showed you, that is, 2 most important messages here is that it is possible to change clinical behavior through the use of performance measures, and 2, that participation and compliance with the performance measures were actually associated with a higher survival rate. So compliance with the performance measure matters, and time to treatment also now in the study that I just showed you at the end matters. So really important data that show that we can make a difference in these patients with severe sepsis and septic shock. We can change clinical behavior, and we can make a difference in survival. And with that, I'll say thank you for your attention, and I really appreciate being able to be here with all of you today on this Global Sepsis Day. McMetin?
Thank you very much, Michelle. Very impressive presentation and results. Thank you very much, really. But I'm thinking about my country. We don't have such a program, and therefore we don't measure the compliance of our colleagues in Turkey. How can we transfer your experience to other countries, and how can we put pressure on our governments or several countries' governments to put this kind of regulations in their agenda? What do you offer to us?
Well, I think that's a great question, McMahon. First of all, I believe that the volume of the published literature right now would be one way that I would think and suggest that you go to the federal government, certainly the health department, because I think the evidence in the literature is fairly compelling that compliance with these measures are associated with improved survival. And in addition, these even in most countries, all we're showing is the administration of rapid administration of antibiotics, obtaining blood cultures, and giving fluid administration. So these are available to the large majority of cultures. In addition, on the Surviving Sepsis Campaign website, we do have the ability to enter data and measure performance. So it's possible to help other cultures and help your government to measure people's performance and hold clinicians accountable for their performance, because the data in the literature strongly suggests that audit and feedback to clinicians about their performance is the best way to change the clinical behavior.
Okay, thank you very much. Time is over. It's going too fast. Thank you very much for your very impressive results. And we turn off to second speaker. Good evening, and see you during discussion period.
Thank you.
Okay, our second speaker is Simon Finfer from Australia, from Sydney. He is professor in medicine at the University of New South Wales and clinical professor at the University of Sydney. He is a past chair of the Australian and New Zealand Intensive Care Society Clinical Trials Group. He chairs the Council of the International Sepsis Forum and is a member of the Global Sepsis Alliance Executive Committee. His speaking topic is evidence-based therapy. What is new? Simon, it's your turn.
Thank you very much for the introduction and for the opportunity to speak to people today. My topic is evidence-based sepsis therapy, what's new? And unfortunately, there are not any major breakthroughs in terms of new drug treatments for sepsis, despite a great deal of effort from both independent investigators and industry over a number of years, and certainly nothing in the immediate past that has caused a significant change. And you may already have heard some of the discussion about changes that have resulted from really process changes in how we use the current basic treatments that are available to us that can reduce mortality. The best recent summary of the evidence over how we should be treating patients with sepsis comes from the Surviving Sepsis campaign, which published the most recent iteration of the guidelines for the management of sepsis and septic shock in 2016. These guidelines were published both in intensive care medicine and in critical care medicine early this year, 2017, an extensive review which had taken 2 years. The guidelines give 93 statements on the early management of sepsis and septic shock, and obviously in the time available to me I can't go through all of those, so I have selected some. They produced 32 strong statements, 39 weak statements, and 8 best practice statements. To understand how they classified these statements in terms of the strength of evidence behind them, a strong recommendation is something that the guideline panels felt that most individuals in the situation would want that recommended treatment, and only a small proportion would not. Whereas for a weak recommendation, the majority of individuals would want the suggested treatment or course of action, but many would not want that. And for clinicians, a similar feeling that for a strong recommendation, most individuals would want the treatment or the action, and adherence to the recommendation according to the guideline could be used as a quality or performance indicator. Whereas for a weaker recommendation, there would be circumstances in which it would be appropriate to use different treatments. So I'm going to concentrate on some aspects around initial resuscitation. They were not able to give really strong recommendations in terms of evidence that sepsis and septic shock were medical emergencies and treatment and resuscitation should begin immediately, although there is clearly evidence has emerged from observational data that the earlier sepsis and septic shock are treated, the better the outcome. They also recommended, again, similar to previous iterations, that there should be a rapid fluid resuscitation involving at least 30 mils per kilo of an IV crystalloid fluid within 3 hours, although this is based on low quality evidence. And again, these are recommendations predominantly, for adult patients rather than for children. The evidence for rapid administration of intravenous antibiotics within 1 hour, is observational data. We're not going to see a randomized controlled trial ever that suggests that compares early and late administration of antibiotic. And I think that's something that we're going to all agree should be done as quickly as possible when one has identified a patient as having sepsis. Probably the critical thing in terms of avoiding unnecessary administration of broad-spectrum antibiotics is to have a policy of de-escalation in that regard. You may already be aware of the analysis of the data conducted by Christopher Seymour and colleagues that was published in the New England Journal very recently, which looked at the outcomes of patients treated in New York State, where there are now state-based regulations that require each hospital to have a protocol for the early identification of treatment of sepsis. And this produced some very interesting data in terms of the outcomes related to the compliance with these protocols. This backs up some of the earlier data that we had about from Anand Kumar and colleagues from Canada, that delays in administration of antibiotics were associated with worsening in outcome. So the New York data was looking at compliance with a 3-hour bundle of management for severe sepsis and septic shock, and this protocol involved recommended the drawing of blood cultures prior to the administration of antibiotics, the measurement of a blood lactate level within 3 hours of protocol initiation, and the administration of antibiotics. And compliance with the protocol, the time to compliance was associated with a better outcome. The earlier the compliance, the lower the mortality rate. Now, clearly, the only therapeutic part of that 3-hour bundle is the administration of antibiotics. Measuring blood lactate and drawing blood cultures can't change outcome. So clearly any beneficial effect there is going to be related to the administration of antibiotics. The 6-hour bundle, which included the administration of the 30 mils or cc's per kilogram of fluid and the administration of vasopressors, and again a remeasurement of lactate, those were the 3 components that were included in that bundle. What they found, and again you may be aware of these data, was that after adjusting for the risk of death based on the baseline characteristics of the patient, there was a clear association between earlier completion of the 3-hour bundle and again earlier administration of antibiotics, which was the only therapeutic component of the bundle, that completing those earlier was associated with a reduction in mortality. Interestingly, and this is fairly novel data, the risk-adjusted mortality, in-hospital mortality, was not, there was not a significant association with the time to completion of fluid bolus. It's difficult to interpret these data. These were patients who were hypotensive, who required a fluid bolus. And clearly it may be that the focus that we have had on the administration of fluid is something that is not supported by such strong data. However, clearly when patients are hypotensive, we would want to treat that hypotension, and there is a recommendation to consider the use of vasopressors, possibly prior to giving a great deal more fluid than we have done in the past. These data are backed up by some interesting new studies looking at more restrictive approaches to the administration of fluid. There is some studies being conducted by the Scandinavian Critical Care Trials Group in which they are comparing restrictive versus a more liberal administration of fluid in patients with circulatory insufficiency due to septic shock. The restrictive component of this is I would consider very restrictive. The study that they have conducted, in the restrictive arm, they were giving crystalloid fluid boluses only if the mean arterial pressure was less than 50, the serum lactate was greater than 4, and there was peripheral mottling. Whereas in the standard care arm, crystalloid boluses were given as long as either static or hemodynamic variables were improved by the further administration of fluid. In their phase 2 or pilot study, which they published recently, it's a relatively small study, being a phase 2 study. 151 patients were included in the study. And they found that while there was, again, it was a phase 2 study, it wasn't designed to be large enough to report on mortality or survival differences. There wasn't a difference in that, although the point estimate favored the more restrictive policy. Other measures such as the occurrence of ischemic events during the intensive care unit and worsening of acute kidney injury were also favoring an approach that was more restrictive in the administration of fluid. So this raises the question whether a more liberal use of vasoactive drugs and the administration of less fluid may be beneficial in patients with septic shock. I think it's important for people to realize the primary recommended vasopressor is norepinephrine at the current time, and that norepinephrine does have beta-adrenergic effects. It does cause venoconstriction, which has the same effect as administration of fluid, and it's possible that using vasopressors earlier in preference to a great deal of fluid may be beneficial. The Scandinavian group, along with others, are pursuing this line of investigation, and there will be larger studies that may be able to guide our fluid therapy in the future so that we are conducting this part of sepsis resuscitation with a greater evidence base behind us. As I've said, the recommendation from the Surviving Sepsis Campaign is still that we use norepinephrine as the first choice vasopressor, and second to which could be added vasopressin or dopamine only in very selected patients. The evidence in favor of adding vasopressin is only based on a very moderate quality of evidence. A recent article reported on the use of angiotensin II for the treatment of vasodilatory shock. This was published in the New England Journal very recently, and this wasn't considered in the guidelines because the data are too early for that. The study looked at patients who were on quite high doses of norepinephrine, and then the outcome measure for the study was whether blood pressure was elevated without an increase in the use of additional norepinephrine. What they found was that the use of angiotensin did improve the blood pressure, which is not surprising, but there was a trend in the paper towards a reduction in mortality, which would support moving on to a larger trial. There are as I said, my time does not allow me to go through the very extensive, comprehensive look at the evidence that was produced in this guideline documents, which is much bigger than the previous guidelines. But I would certainly recommend that anyone who's managing patients with severe sepsis take the time to read the documents, read the recommendations, and also look at the evidence behind it. Probably what has led to the most likely reduction in that we're observing a reduction in the mortality from sepsis around the world. It's still obviously a major global health problem, but we are seeing some benefits. And a lot of that benefit comes from raising awareness, which is where a lot of effort is done. And although there clearly is, we're not going to get randomized controlled studies that look at sepsis awareness, there's again a clear association between raising awareness, as it's been done notably in the United Kingdom and in other countries, into improving the outcome. So I would recommend, to wrap up, I would recommend that to people who wish to practice evidence-based practice related to the management of sepsis and septic shock, that you can't do better in terms of a single source of information than to go to the Surviving Sepsis Campaign guidelines. And I've just hopefully given a little taste of the evidence that they produced.
Simon, thank you very much for your presentation. But okay, now we have a new guideline, but in a short time, possibly, we should change it according to Scandinavian study results. Possibly in future, we can apply less fluid and more vasopressor. But I have a question. For example, in my country, well, we don't have vasopressin. Instead of vasopressin, we are using terlipressin. It exists in my country. It has approximately same effects. What do you think to use of terlipressin instead of vasopressin in such cases?
Well, I think to not quite answer your question immediately, I think one of the things that we do have to do in the future is the Surviving Sepsis Campaign guidelines are very much focused towards the United States and Europe and other high-income countries. And most, 85% plus of the world's population live in low and middle-income countries where a lot of the treatments and management protocols discussed may not be available. So we do need to produce guidelines that are applicable in other settings in low and middle income countries. The evidence for the use of terlipressin or other vasopressors where vasopressin is not available, I don't believe there is strong evidence that I could make a recommendation that you do or do not do that. There are comparative studies that have looked at compared norepinephrine and epinephrine. A lot of people shy away from epinephrine because it produces a hyperlactatemia, which may be confusing in terms of whether a patient is responding to treatment or not. Although that is transient, and if you look at the studies led by John Myberg that looked at the compared epinephrine and norepinephrine in terms of outcomes, mortality, and time to wean from vasopressors, there's no difference. But epinephrine does cause a hyperlactatemia, which can confuse people in terms of who are using lactate as a marker of whether the patient is improving or not. There isn't a good evidence base to make a recommendation on other vasopressors.
Okay, thank you very much. There is a last question from the audiences. What do you think about the use of corticosteroids in pregnancy?
So the data for or against the use of corticosteroids, the adrenal study, which has been conducted by the ANZIX clinical trials group led by Bala Venkatesh, has completed. We're about to lock the database, and hopefully either by the end of this year or very early next year, we will report the results of this trial, which is 3,800 patients, which is more than considerably more than all the patients in all the other studies so far reported. We don't know the result yet, and hopefully that will clear up this controversy for once and for all. Current recommendation is to consider the use of steroids in patients who are poorly fluid and vasopressor responsive. Jalali Anane did present in the Brussels meeting earlier this year results from his study, which he again reported a mortality benefit from the use of a combination of hydrocortisone and fludrocortisone. That study was completed recruitment over 2 years ago and is not yet published. And I think we should not act on those results until the study is published. And that will likely, I don't know whether that's going to occur before or after the adrenal study, but the adrenal study will be by far and away the strongest evidence for or against the use of hydrocortisone in patients with septic shock. Currently, the Surviving Sepsis campaign guideline is to consider it. It's a weak recommendation in patients who are poorly responsive to fluids and vasopressors. And we really need the results of the adrenal study to make a stronger recommendation on that.
Okay, thank you very much for your presentation, also for your answers. We are switching to third speaker of the session, William Hamilton, health service executive from Ireland. She is consultant in anesthesia and intensive care. Dr. Hamilton is an honorary senior lecturer in the Royal College of Surgeons in Ireland and tutor in anesthesia for the College of Anesthesists of Ireland, and is honorary secretary for the Joint Faculty of Intensive Care Medicine in Ireland and council member of the Intensive Care Society of Ireland. She is representing the council at the sepsis section of the European Society of Intensive Care Medicine. She is the clinical lead for sepsis, sits on the National Sepsis Steering Committee, and is co-author of the National Guidelines on Sepsis Management and is leading the implementation program. Her speech topic is Sepsis Quality Improvement Initiatives Save Lives. Dr. Hamilton, please, it's your turn.
Thank you very much, and good evening, everyone from Ireland. So I'm going to talk a little bit about sepsis quality improvement. And in the 2016 Surviving Sepsis Campaign Guideline Update, there was a new recommendation, and that was that hospitals and hospital systems have a performance improvement program for sepsis. And this was based on a meta-analysis of around 50 observational studies that showed in the presence of a quality improvement program, there was a significant increase in compliance with the campaign bundles, and this was associated with a reduction in mortality with an odds ratio of 0.66. So what are the issues? Well, when we approached our quality improvement program, we recognized that there was evidence behind early recognition and treatment, giving patients the best opportunity to survive. But this then had to be balanced against overdiagnosis and overtreatment with antimicrobials, in this environment of concerns with growing multi-drug resistant organisms. And certainly physicians whose behaviour were keen to change towards an early recognition and treatment protocol certainly had great concerns about overtreatment. And another big concern was that with an overemphasis or potential overemphasis on sepsis, there could be misdiagnosis and the actual cause of a patient's deterioration being missed and having delayed treatment because, as it turned out, it wasn't sepsis. Other concerns was the loss of clinical autonomy and the loss of flexibility in clinical practice associated with a checkbox approach to medicine. And this is something that's of ongoing concern with clinicians. And then, of course, achieving behaviour change is hard. It requires energy to change behaviour, and therefore you need to have a really good rationale for changing your behaviour, and it's also difficult to sustain it. So you have to really believe in what you're doing and have faith in the data. So in Ireland, we have a government mandated sepsis quality improvement programme. It's led by a multidisciplinary steering committee with representation from all specialties and all services, recognising that sepsis, of course, occurs in all specialties and all services. And this is one of the issues with sepsis. Because it occurs to all specialties, it belongs to no one specialty. And because it's everybody's problem, it becomes nobody's problem. Nobody takes ownership. So our desire in our program is that all specialties and all services have the competency to recognise patients who are at risk of sepsis and to initiate the Sepsis 6 1-hour bundle adapted from the bundle developed by Ron Daniels' group. We published a national guideline in 2014, which was adapted from the Surviving Sepsis Campaign guideline and including the Sepsis 6 1-hour bundle. Our guideline is mainly orientated towards initial recognition and the initial treatment bundle and then escalation to specialty care. So it's orientated at the emergency department and the patient deteriorating on the ward. And the implementation of the guideline is led by the national team. We believe in very strong leadership, and we have had an annual sepsis summit, which is opened by our Minister for Health. And at the first summit, we requested hospital managers and lead clinicians to create sepsis committees in every acute hospital in the state. And we also started our outcome audit process. And we use our hospital inpatient inquiry system, which is an ICD-10 with the Australian modification and the 8th edition. And that's got a little bit more inbuilt flexibility than the American ICD-10. So we looked for very clear outcome aims. Within 5 years, we're looking for a 20% reduction in sepsis-associated hospital mortality, and we clearly defined processes to achieve those aims. And those processes, we required them to be evidence-based, and we clearly assigned roles and responsibilities, not just for clinicians, but for the Department of Health, for the Health Services Executive, for the hospital group managers and leadership teams, for the hospital leadership teams, through to the clinicians. And we instituted a process of measurement using our HYPE database for outcome data, but also using chart review for process measurement because we do not have an electronic patient record system. We took a multimodal approach to achieving our process aims. We recognise absolutely that the just do it approach does not work. It requires strong leadership at a national level, but also at a hospital level. And sepsis champions have had a huge impact in the hospitals that are most effective at implementing the programme. Education compliant with the national guideline is now occurring at an undergraduate, postgraduate, and at a hospital-based level. We've involved end users and service users in our process development. We adapted clinical decision support tools, working with the different specialties so that it would, one, work within their working environment, but two, because they were involved in the development of their clinical decision support tool or sepsis form, they took ownership of that form, and it helped reduce the barriers and reluctance to use the forms. We tried to make things easier to do the right thing than not to do the right thing. In a very busy environment, something that increases workload will be much more difficult to institute than something that reduces workload. So using sepsis trolleys, having clinical decision support tools to help support clinicians, and often the first line clinician is relatively junior with maybe only 2 or 3 years hospital experience, and we're looking for a generational change so that having come through undergraduate and postgraduate education and hospital-based training, all supporting our sepsis implementation program, that it'll become the norm rather than something new that has to be done. So in order to convince our clinicians that what we were doing was not wasting their time, our first audit in 2016, really we were looking to answer the question, is using the sepsis form useful or not? We audited just under 1,500 charts, and we found that if the form was used, you were more likely to get the diagnosis correct. It was more likely to be documented correctly at the appropriate severity level, and the patient was more likely to receive their first dose antimicrobials within an hour. We noted that just over half of patients with sepsis were actually documented in the case notes as having sepsis. In 2017, we looked at a smaller number of charts, just under 500, but at a much granular approach. We were looking for compliance with taking blood cultures, antimicrobials within 1 hour, whether the antimicrobial given was as per the local guideline. We have a very strong antimicrobial stewardship program, and no sepsis education presentation is done without including antimicrobial stewardship. And we found that, we're in around 60-70% compliance with components of the bundle, but very reassured and very reassuring for clinicians who had concern with excess carbapenem administration consequent to the program. Our compliance with the with local antimicrobial guidelines is at 80%. Of note, taking a fluid bolus approach to fluid resuscitation is the weakest element of our sepsis bundle. And that corresponds, I think, to uncertainties about the right way to fluid resuscitate. We have just launched our second National Sepsis Outcome Report in the beginning of this month, and we've demonstrated a 67% increase in the cases documented in 2016. And this is consequent to the awareness and education campaign and represents improved documentation rather than an improved an increased number of cases. We're also able to follow our hospital mortality trends, but we're also conscious of the fact that improved recognition and documentation will skew the results because less acute sepsis cases will be documented. So while we have a 31% decrease in sepsis mortality over the past 5 years, it's a little difficult to interpret that. What we can say is that the Irish hospital sepsis-associated mortality rate is 19%, and that excludes patients with a SIRS response of an infectious origin without organ dysfunction. So that's a sepsis-3 mortality rate, and certainly that is very reassuring, and we'll continue to follow the trends. quarterly analysis just demonstrates that, in fact, it's not statistical variation that is the cause of the mortality decrease. Our HYPE database also allows us to identify the patients at higher risk of mortality within our population. So, mortality increases with age, it increases with comorbidities, and it increases also if you're in a surgical, a diagnostic related group as opposed to a medical diagnostic related group, and gender has no impact. So we were able to use this data to inform our updated sepsis forms to be compliant with the sepsis 3 definition. And what we recommend now that patients who present with infection plus one of the following, either they're immunosuppressed due to therapy, they present with clinically overt new organ dysfunction, or if they present with a SIRS response due to infection and have one comorbidity, they should receive the Sepsis 6 bundle within 1 hour of identification. And as part of that bundle, their blood tests to assess organ dysfunction are sent off, and by 3 hours then they need to be reviewed. The patient is reviewed in terms of their diagnosis with the results of the tests and investigations available to date, and also the clinical response to the Sepsis 6 bundle. Sepsis is diagnosed yes or no, consequent to the presence of acute organ dysfunction, and if the patient requires escalation to specialist care for either source control or critical care input or both, then that should have occurred by then. And then at the 6-hour review, patients who have been hemodynamically unstable with fluid-resistant shock should be started on pressors. Also at the Sepsis Summit at the beginning of this month, where we launched our outcome report, we launched our maternal sepsis program. So for the past 12 months, we have been piloting sepsis forms to identify patients who should receive the Sepsis 6 bundle, and then similarly by 3 hours diagnosed with sepsis or not, and their treatment amended accordingly. This poster here represents our part of our publicity or awareness campaign for maternal sepsis. So this is aimed at the service user. It talks about the risk factors that are associated with increased mortality or increased incidence of sepsis, and it also provides a checklist of the different symptoms and signs of organ dysfunction. And we also tie in infection and sepsis prevention with good hygiene, good sanitation, promoting vaccination, and promoting breastfeeding. In our maternal sepsis form, we identify 3 groups of patients to receive the Sepsis 6 bundle. Patients who present with infection who are on treatment, that puts them at risk of neutropenia. Patients who present with symptoms of infection and clinically apparent organ dysfunction, and patients who present with a sustained SIRS response. So those 3 groups of patients get the Sepsis 6 bundle, and then subsequently, when the blood tests become available, sepsis is diagnosed or not, and the patient escalates accordingly. So within 12 months, we'll be reviewing our different patient groups, and we will be assessing them for sensitivity and specificity, and then updating our treatment groups based on that data. Thank you.
Thank you very much. Very impressive presentation. And this is a success story, really. Now I am presenting 4th speaker. She is Holly Prescott. Prescott from Dr. Prescott from United States. She is actually a doctor and researcher at the University of Michigan and Ann Arbor VA Hospital. Her research focuses on sepsis survivorship. Taken together, Dr. Prescott's studies have highlighted the role of specific treatable medical conditions in driving post-sepsis morbidity. Dr. Prescott, it's your turn, and her topic is enhancing sepsis survivorship. Please, Dr. Prescott.
Great. Well, thank you for the introduction, and it's really my honor to be participating in the WSC Congress. I'll start out with this article that was published in the American Journal of Respiratory and Critical Care Medicine in 2006 by Fleischman et al. This article estimated the global burden of sepsis, and the best estimate was 19.4 million severe sepsis cases around the world each year and 5.3 million sepsis-related deaths. When you take those two numbers together, you see that about 15 million patients survive sepsis each year around the world. And this number is likely increasing over time as a result of increasing numbers of hospitalization for sepsis, as well as improving in-hospital mortality. And yet we have very little guidance about what to do for patients after hospitalization to promote a better recovery. For example, the Surviving Sepsis Campaign guidelines, which provide fantastic recommendations about what to do for patients during the hospital, do not provide guidance yet about what to do for patients after the hospital to try to promote recovery. We also know that patients currently are not completely satisfied with the support services that they receive after sepsis. For example, in a recent web-based international survey of about 1,500 sepsis survivors, they were moderately dissatisfied with the quality of care. For example, moderately dissatisfied with the quality of information that they had received about what to expect after surviving sepsis. And so the question that I'll be discussing today is, what can we do today to try to enhance survivorship for sepsis? And of course, there are many different answers to this question and many different things that we can be doing for our patients, but I'm going to be focusing on just one answer tonight, and that is preventing further medical deterioration in our patients after they survive a sepsis hospitalization. A couple years ago in American Journal of Respiratory Critical Care Medicine, I had a study that was a nationally representative cohort study of older Americans who had survived a sepsis hospitalization. And we followed them over time for the 12 months after hospital discharge and looked over time at the proportion of these patients that were admitted to an inpatient healthcare facility and the proportion who had died. And we found very high rates of inpatient healthcare utilization, particularly in the first 90 days after discharge from sepsis hospitalization. Much of this was time spent in nursing facilities and rehabilitation facilities, but there was also a very high rate of hospital readmission. About 42% of the patients in this cohort were rehospitalized within 90 days after discharge. And then we wondered, what are these patients coming back to the hospital for? And is there something we can do to prevent these readmissions that are certainly making it harder for patients to make a long-term recovery? We know that during the early phases of sepsis that patients have both pro and anti-inflammatory responses, but the balance is tipped generally towards a pro-inflammatory state. But then as time goes on with sepsis, most patients are tipped towards an anti-inflammatory phenotype. And so in the later stages and early after sepsis, patients are at increased risk for secondary nosocomial infections, for viral reactivation, and for infections with weakly pathogenic organisms. And we also know that patients who die after sepsis show evidence of immune suppression, suggesting that boosting the immune system may be a way to try to improve outcomes in these patients. And so we wondered whether these processes that are occurring during the hospitalization continue on in the outpatient setting, whether this immunosuppression continues and patients are at increased risk for subsequent infection. And so we looked at recurrent sepsis in my hospital. We followed all patients who were discharged over a 2-year period. We found that about 30% of all patients were readmitted to our hospital, almost certainly a higher number if we were able to capture readmissions to other hospitals. And then of these patients who were readmitted, 29% of them were readmitted for another episode of sepsis. We then dug a little bit deeper into the data to try to understand the causes of these episodes of recurrent sepsis, whether they were, relapse or recrudescence of that initial infection, meaning that the infection had the same site and same organism as the initial episode, or whether these were new infections. And we found that only in 19% of cases was it definitively the same infection, the same site, and the same organism. 47% of the time, it was definitively a different infection, either a different site or a different organism. And about 35% of the time, it was culture negative. So overall, about 50 to 80% of the time, this is a new infection, suggesting that the majority of recurrent sepsis is not incomplete treatment or relapse of this initial infection, but really that patients surviving sepsis are at increased risk for a variety of different infections, that this continues for months after hospital discharge and is one of the main drivers of hospital readmission. But again, this represents only 30% of the readmissions in this cohort. So then we looked at all causes of readmission to try to understand what are the most common reasons that people come back to the hospital. And so here I present an observational cohort study of about 2,600 older Americans who survived a sepsis hospitalization. And here too, the most common readmission diagnosis was sepsis, which occurred in 6.4% of the cohort was readmitted with sepsis in the next 90 days. Other common things were other types of infections, such as pneumonia and urinary tract infection. And then we also noted many different readmission diagnoses that are potentially treatable in the outpatient setting, such as congestive heart failure, acute renal failure, COPD exacerbation, and aspiration pneumonitis. And so for my recommendation today for what we can do to try to enhance survivorship is to focus on these most common and potentially treatable or preventable causes of hospital readmission. And so when we take this list, we can distill it down to what I call the big five preventable causes of readmission after discharge. So the first one, by far the most common, is infection. And so things that we can do today during the hospitalization are to focus on antibiotic de-escalation. We know that antibiotics are incredibly important early on, but the longer patients are exposed to broad-spectrum antibiotics, they also experience disruption of healthy microbiota. And so we should be working to try to provide shorter antibiotic courses to our patients. We also need to counsel patients on infection, the very high risk for recurrent infection. We know that many patients are not aware of sepsis, and even patients who have survived sepsis don't often know that that's what they've been diagnosed with. And so it's critically important to inform patients that they are high risk of recurrent infection, of recurrent sepsis, and that if they experience signs of symptoms of infection, they need to get back in touch with their doctors, particularly if these are accompanied by signs and symptoms of organ dysfunction, such as confusion or decreased urine output. This is also a good time to make sure that patients have been updated on all of their recommended vaccines. In the future, we may have other tools in our toolkit, such as modulating or boosting patients' immunity after sepsis, or repopulating microbiome that has been disrupted due to sepsis or broad-spectrum antibiotics. The next most common cause of readmission, congestive heart failure. This is a very important time, these first few days and weeks after sepsis hospitalization, to focus carefully on patients' volume status and also their medications. Many patients with heart failure are on beta blockers, ACE inhibitors, diuretics, medications that are routinely held during sepsis, and for which it might not yet be time to restart them at hospital discharge. We need to carefully watch patients to determine when to resume these medications and whether the dosages need to be altered. We need to keep in the back of our mind that patients may have worse myocardial suppression as a result of surviving sepsis, and they may have ongoing renal impairment as well. And these may contribute to difficulties in controlling volume status and contribute to worsening heart failure or readmission for heart failure. The next most common preventable cause of readmission is acute renal failure. And here too, we need to worry about whether patients have ongoing kidney injury or lingering myocardial suppression after the sepsis hospitalization. For patients who have had kidney injury and not had complete recovery, I think that it may be important to monitor blood work and ensure that patients trend the right direction, or that they, at the least, that they stabilize, as opposed to having slow worsening of kidney function after hospital discharge. We need to carefully monitor medications here too, such as diuretics, nephrotoxic agents, renally cleared medications, and adjust the dosages as needed for patients. The next most common cause is COPD exacerbation. So here too, we want to make sure patients are updated, have received their current vaccinations, or receiving recommended controller therapies for their disease. And we want to consider whether any of the medications that the patient's taking are perhaps respiratory depressants, such as benzodiazepines and opiates, and whether those dosages need to be adjusted due to new kidney failure or whether medication should be discontinued. The last on the top 5 list is aspiration. Here we want to screen patients for new physical weakness, cognitive impairment, ongoing delirium, all of which increase patients' risk for aspiration in the post-sepsis setting. We want to consider for patients who screen positive for these things, whether they would benefit from having a formal swallow evaluation, whether they should have dietary or behavioral modifications to reduce their risk. Here we see again the rate of readmission over time. About 40% of older Americans readmitted sometime in the 90 days after sepsis hospitalization. More than 1 in 5 has a readmission for one of these potentially preventable causes. And so this top 5 list is the things that I focus on, the things that I think that our health system should focus on in those early weeks and months after sepsis hospitalization to try to keep our patients out of the hospital and give them time to recover. Again, this is just one answer, and I think that there are many other ways to enhance sepsis survivorship, things that we can do in the hospitalization, at the time of discharge, and after discharge to help promote recovery. But here I'll close with just putting up the top 5 list again, and I'm happy to take questions. Thank you.
Thank you very much, Dr. Prescott. It's impressive, but I'm getting a bit pessimistic when I hear your results. According to your result, approximately 60% of patients are dying within 1 year of discharge, and their quality of life possibly very low. And can we say that if we discharge patients with chronic organ dysfunction, then we don't have long survival chance for those kind of patients?
Yeah, I mean, I think that that's true. I mean, people who have lingering organ damage, I suspect do have increased risk of, late mortality. And we know that there's this very high of risk of late mortality. In prior studies, we've estimated that about 1 in 5 patients who survives a sepsis hospitalization goes on to die sometime in the next 2 years due to lingering consequences or lingering effects of sepsis, meaning that it's not explained by their age or to medical conditions that they had prior to sepsis. So I think you're absolutely right that this lingering damage causes morbidity. It also causes late mortality.
Okay, another question. I know your study is especially about microbiomes. Mm-hmm. We are using antibiotics, sometimes less, sometimes more than necessary, and we are losing our microflora. What can we do to speed up microbiome repopulation?
Right. No, I think this is a critically important question. And there was just recently a study that was published in Nature where they gave symbiotics to about 4,500 neonates in India, and they found a significant reduction in the incidence of sepsis. And so my sort of question, what I wonder is whether we will not be using this for more types of patients, and particularly patients who have survived sepsis, where we know microbiome is frequently disrupted, and we know patients have an incredibly high risk of recurrent sepsis. I will say we don't have specifically data in this patient population, but I'm hoping that, in the next 5 years that we should have data on that, and I'm hoping that that will be a potentially effective therapy.
Okay, one more question. According to your results, 19% of the post-discharge infections are occurring at the same site with same organisms, and 28% of infections occurring at the same site, but those are culture negative. Okay, it's repeating at the same site. Something should be wrong because it's occurring mainly at the same site, previous infection site. What we are missing?
Yeah, I think that there's, several different answers, and, we didn't have enough people in that study to really try to tease it out, but I've got a few hypotheses. So one, I think, is that there's people who have, chronic lung disease who may be colonized and are at increased risk for pneumonia. And then they're just sort of always going to be at increased risk for pneumonia if they're colonized with a particular bug and have sort of local anatomic abnormalities because of some sort of chronic comorbidity, such as chronic respiratory disease. But then I also wonder if there's perhaps local microbiome disruptions or local immune system dysfunction that could also be contributing, because again, many of these are culture negative. They're not necessarily the same bug for the recurrent admission. And typically, if you are colonized with something, you will be able to grow it out. So I suspect that there's a couple different mechanisms, and that there's certainly more work to be done to try to tease that out and to see if there's sort of local therapies we can do to try to reduce recurrent sepsis.
Okay, thank you very much. There are more questions to ask you, but we don't have time. I hope we can ask more at the discussion period. Thank you very much, Dr. Prescott.
Great, thank you.
Okay, our first speaker is Flavia Machado. Flavia is Professor of Intensive Care and Chair of the Intensive Care section of Anesthesiology, Pain and Intensive Care Department at the Federal University of Sao Paulo in Brazil. She has been working with the Latin American Sepsis Institute since its foundation in 2005. She is a member of the Surviving Sepsis Campaign International Guidelines Committee. She is a member of the Executive Board of Global Sepsis Alliance and also member of Executive Committee for the World Sepsis Day. She is also a member of the Executive Committee and Scientific Committee for the Brazilian Research in Intensive Care Network. A lot of work for Flavia. And now we are switching to her presentation, and the heading of his speech is the new sepsis definitions, pros and cons. Please, Machado, microphone is yours.
Thank you, Nekmeti. It's a great pleasure to be here and talk about the new sepsis definitions. As you know, sepsis is now defined as a life-threatening organ dysfunction associated with a dysregulated host response to an infection. And as we know, there are many pros and cons of these definitions. Let's start with the last numbers. It is true that the new definition brought some attention to clinical signs that otherwise were neglected, like the reduced level of consciousness and the respiratory rate. It is also true that due to the high specificity, the new definitions might be better for the assessment of new therapies. And it's also true that the new definitions, for the first time, were based in data, because the last definitions were more based on expert opinion. And now these definitions were based on a large database coming mostly from US, but also from German. But anyway, from high-income countries, which is actually an issue. But the reason for that is that we don't have data coming from the low and middle-income countries. The second point, which is also a good thing, is the simplification of the nomenclature, because that thing about SIRS, severe sepsis, and sepsis, it was a little bit too complicated. And to send the proper message, calling sepsis a severe thing, it's a good thing. To associate sepsis with organ dysfunction, simplify the message that we have to do to send to everyone, lay people and healthcare professions. The third positive point is that SIRS is no longer required for the definition. It is good because sometimes we have very sick patients that do not comply with the SIRS criteria. They don't have any SIRS criteria, but they certainly had sepsis or septic shock. However, it is we need to say that the SIRS is still important for screening, because screening using SIRS will let us find infected patients, and finding infected patients is a key step to find septic patients. So what are the problems? I would say there are three major issues. The first one is the use of the variation in SOFA score as the clinical criteria to define organ dysfunction. Why this is a problem? Actually, this is a slide that Mervyn Singer showed in a recent meeting in Brazil, and he said, we should not stop to calculate SOFA scores. We need to look at our patient, and if the patient have any organ dysfunction, and here we have lactate included, we need to act, which means we don't need the score to prompt us to act. This means that at bedside, we should not use this variation in SOFA score to define or to see that a patient has sepsis. This brings us a problem because at bedside, we will not use the definition. And it is not good when we have a definition that we cannot use at the bedside. It's not good when we have a definition that can only be used or was meant to use in epidemiological or research. Another problem is that the variation in SOFA score was chosen as a definition of organ dysfunction based on Rocky curves. The Rocky curve for the variation in SOFA score was better than the Rocky curve for SIRS, and that was the reason why it was selected. However, I don't need a Rocky curve to see that SOFA would predict mortality or the need for ICU better than some inflammatory criteria. Of course, SOFA will predict this better. The SOFA score was not compared with our previous definition of severe sepsis, which was any organ dysfunction. And this is a major problem. Another problem is a philosophical one. Why do we need to base our definition in a Rocky curve, which will bring us to the better balance between sensitivity and specificity? We, in the low-income countries, are still seeking for definitions or seeking for sensitivity, while this might not be the interest or in the high-income countries, which are now seeking for more specific definitions. And the reality is completely different. For instance, recently we had the opportunity to publish in Lancet Infectious Disease this study in a random selection of 50% of all Brazilian ICUs. And we show that our mortality rate, at least in the ICUs, is 55%, which is really very high. So our reality is different. So I think that we need to look at simple definitions and sensitive ones. And for instance, if we use SOFA score of 2, we will leave outside of the sepsis definitions patients with hypotension and reduced level of conscience. As this patient, we're going to have only a SOFA score of 1. The other problem is the definition of septic shock. As we know, septic shock is now defined by the presence of a lactate over 2 after fluid replacement and the need of vasopressors. And this end was voted against a NOR, and the difference in votes were just 2, which means it could have been a NOR, lactate, or vasopressors. And we think that it's not fair with many countries in the world that doesn't have lactate available. For instance, there is this paper coming from Uganda where 89% of the institutions can never measure lactate. So how can we have a definition of septic shock that cannot be used by the low and many middle-income countries? The third problem, it was the new score, the Q-SOFA score. As you know, together with the new definitions, there was a suggestion that there is this new score that would identify patients that are prone to die or prone to be admitted in the ICU. And the positive Q-SOFA score is composed by 2 of the 3 components: a higher respiratory rate, a low systolic blood pressure, and a reduced level of conscience. There is no problem at all in having Q-SOFA as a severity score. However, in the paper, there was this figure that suggested that Q-SOFA might be used to screen patients and to identify patients that have sepsis. It is true that the authors of the task force have clearly stated in the paper that this score needs to be validated. And it is also true that Mervyn Singer, for instance, in the same lecture that he gave in Brazil, stated clearly that QSOFA has never intended to be a screening tool. However, that figure in the paper have caused a lot of confusion, and many hospitals, many emergency departments, and in many wards all around the world, people started to use QSOFA as a screening for sepsis, which might have generated a lot of issues. A screening tool is something completely different from a decision-making tool. QSOFA is a severity score. It is not validated as a decision-making tool. And the reason for that is because a decision-making tool in a deadly disease like sepsis needed to have a high sensitivity. And all the papers that have been published after the sepsis 3 definition have demonstrated, except for this one, have demonstrated that QSOFA in patients from the emergency departments have a low sensitivity, which means that using this strategy might miss patients with high risk of death. All these pros and cons, the new sepsis definitions, are explained in detail in this paper that is an open access in Journal of Critical Care. This paper was produced by the Quality Improvement Committee from the Global Sepsis Alliance and also from the Executive Committee of Global Sepsis Alliance. And I really suggest that you can have a look on it. So in conclusion, the definitions have changed, but our patient, he didn't. So we do not calculate SOFA to act, but we really need to use the broad sepsis 3 definition, which is life-threatening organ dysfunction to act. The old definition is not and was not perfect. It lacks both sensitivity and specificity. The new proposal has some nice advantages. It is the first data-driven definition. There is no need for search criteria, and the nomenclature is simpler. However, the use of the variation in SOFA score is not simple, and the validation process was inadequate, as it was against SIRS and not against the previous definition of severe sepsis. So there is no evidence that delta SOFA is better than what we used before. QSOFA is not a screening or a decision-making tool. It is a severity score. And this definition that increases specificity will decrease sensitivity. And this might not be good for our quality improvement initiatives. Thank you very much.
Flavia, thank you very much. You are mainly at the practical side, especially for low-income countries like my country. You are right. It's maybe difficult to calculate SOFA in certain conditions, but I would like to tell that SOFA, okay, needs some lab results, but at least 4 components of SOFA score is coming from clinical follow-up. And accordingly, and together with the screening tool, quick SOFA scoring screening system, do you offer us that should we change the scoring system according to the low-income countries' conditions?
Actually, no, Nick-Meeting. No, all the papers I show came from high-income countries, and all of them, the sensitivity of the QSOFA is too low. The problem with QSOFA is not the variables that compound it. I mean, we have been using hypotension, reduced level of consciousness, and dyspnea or tachypnea as alert signs for 10 years now. These are the dysfunctions that our nurses, these are the dysfunctions that the Surviving Sepsis campaign used for 10 years. There is nothing new in the Q-SOFA score, absolutely nothing new. The problem with the Q-SOFA is the use of two components. That's the most dangerous thing. I mean, use one of the three components of the Q-SOFA. That's what we've been using for 10 years. So that's good. Of course it is good. Use any dysfunction. It's good. Using two of the three components, we'll select a very severity patient and we'll miss patients with a single organ dysfunction. That is the point.
Okay. Thank you, Flavia. Very nice presentation and good answer. And time is going to pass, and I should switch to the sixth speaker of the session. Is Philipp Schuetz from Canton Hospital, Aarau, Switzerland. Prof. Schuetz is a board-certified internist and endocrinologist. He currently has a professorship from the Swiss National Foundation and works clinically at the Medical University Department at Kantonsspital Aarau in the emergency department and the endocrine unit, and is in the charge of clinical studies focusing on clinical nutrition as well as on improved triage and management of patients throughout their hospital stay with the use of novel biomarkers, particularly procalcitonin. Heading of his speech is the potential of biomarkers for antibiotic stewardships. Philipp, it's your turn.
Well, thank you very much for your kind invitation. And I look forward to talk a little bit about the potential of biomarkers, particularly for antibiotic stewardship. So I have some ongoing research with diagnostic companies as a potential conflict of interest, which I would like to mention. But then I would like to start and talk about sepsis. And while the big white shark is a very dangerous animal, I think sepsis is a much bigger killer. And we have learned from a lot of recent trials that it's not easy to lower mortality and to improve management of patients by any new fancy drugs. All these new trials really have been disappointing. So we have to come back to the very important points in sepsis care, which is early recognition of patients with sepsis. I think initial resuscitation with antibiotics and also fluids is key, but then also supportive management and diagnostic management are the two components. And so I would like to talk just a little bit about how PCT can help us in these different steps. So first in early recognition and also rule out of sepsis, how can it help us with antibiotic management, diagnostic management, and help us in the overall assessment of the patient and also for duration of antibiotics. So I would like to answer three different questions. First, does PCT provide prognostic information in patients with sepsis? Second, can PCT improve antibiotic decisions? So can it help us to rule out bacterial infection in low-risk patients? But also can it help us to monitor patients which are eligible for early stop of antibiotic therapy? And most importantly, my third question, does the use of PCT improve clinical outcomes in our sepsis patients? I think PCT is an interesting marker when we look at the regulation, because PCT is mainly upregulated by pro-bacterial cytokines, including interleukin-1 beta and TNF-alpha. However, it also has another regulation step, which is a block of the upregulation by other cytokines, interferon gamma, which is a cytokine released in response to viral infections. So I think this regulation is particular for PCT and makes this marker more specific towards bacterial infection and sepsis compared to other markers like CRP or white blood count. So it seems to be a more specific marker and helpful in the assessment of a septic patient. So let me go to the first question. Does PCT provide prognostic information? Well, interestingly, the regulation of PCT is important for its prognostic use. So PCT increases within about 6 to 12 hours and shows a steady decrease if a patient responds well to therapy. We have also learned from clinical studies that patients not responding to therapy have a much less pronounced decrease in PCT. And so if you don't see that a patient clears the PCT level, this usually means that the patient has ongoing infection and the resolution of infection is not well controlled. So when you compare cohorts of patients with sepsis and you compare survivors of sepsis with non-survivors, you will see that the survivors have also very high PCT levels upon admission. However, if they decrease their PCT level, that's usually a very good sign. And in patients not surviving their sepsis episode, you often see a non-decrease in PCT. And so we have recently done a large US-based study, including 13 different sites across the United States, where we validated that the PCT decrease over 4 days has a very strong prognostic value. And so if a patient cannot reduce his PCT level by 80% or more, his mortality is about doubled compared to patients who have a strong decrease in PCT. So the monitoring of this marker really provides prognostic information, which is in addition and beyond the prognostic information you will get just from clinical management of patients or from other scores such as the SOFA score. So prognostic information is one thing, but what are you doing with your prognostic information? And so in the case of sepsis and PCT, I think the most important therapeutic consequence of using the marker is really the change in antibiotic management. And so a variety of larger trials have looked at the impact of PCT on the management of patients. And so these trials were mostly randomized controlled trials comparing patients with and without the use of PCT. We have done a meta-analysis in collaboration with Cochrane and have looked at a large variety of trials, particularly for patients with acute respiratory tract infections in different settings and with different severities of infection. So most of these trials have used similar protocols, how they incorporated PCT for the management of patients. So for the lower risk setting, so for patients for primary care or emergency department patients, the main cutoff that was used was at 0.25. And if a patient was not at high risk and had a lower level, then the recommendation was not to use antibiotics or to stop antibiotics. And you can see that these protocols really had a strong effect on antibiotic use. So in our meta-analysis, there was about a 65% reduction in antibiotic exposure for primary care patients and a 66% reduction for patients with bronchitis. Now, these are low-risk settings and low-risk patients. And for the higher risk settings, so patients in the ICU with sepsis, the protocols were adapted. So first, in these trials, a higher PCT cutoff was used. So the cutoff was 0.5, for which sepsis was deemed to be unlikely. And PCT was not as much used for the initial management of the patient, but it was more used as a monitoring marker for deciding when to stop antibiotics. So if you had a patient come in the ICU with sepsis or suspicion of sepsis and the patient was very sick, you would still use antibiotics on the first day to treat this patient, but then you would measure PCT and would monitor its course. And if you would find a very low PCT or a fast drop in PCT, the algorithm would encourage you then to stop your antibiotics because this would indicate resolution of illness. So these algorithms have really resulted also in a reduction of antibiotic exposure, mainly by early stop of antibiotics. And for the ICU population, it was about a 25% reduction in antibiotics. And for patients with pneumonia, it was almost a 40% reduction in the use of antibiotics, mainly by shortening the courses of antibiotics. Recently, we have also learned that PCT protocols work very well in very small patients. The NeoPIN study that was just published in The Lancet a couple of weeks ago has also shown that for the very small patients, the use of PCT results in a relevant and significant reduction in antibiotic use, and there was no safety signal associated with the use of PCT despite the lower use of antibiotics. So use of PCT to guide antibiotics really results in reduced antibiotic exposure. But can we use the marker and for improving patient outcomes, or do we patients put at risk if we use less antibiotics in patients? And so there was one key study published in 2016 by a group from the Netherlands, Evelyn de Jong and colleagues, in the Lancet Infectious Disease. And this is the largest study today looking at patients in the ICU with sepsis, including more than 1,500 patients across 15 hospitals in the Netherlands. And the study showed that first, PCT was associated with a strong reduction in antibiotics, but also it was associated with a significant reduction in mortality. So the use of PCT really improved the outcome of these patients. So based on all this evidence that we have gathered from trials, recent guidelines also suggest that the use of low procalcitonin should assist clinicians in the discontinuation of empiric antibiotics when there is no evidence of infection in these patients. So again, I think for the septic patients, it's important to use antibiotics in the beginning when you are not sure what's going on in the patient, but the low PCT or the strong drop in PCT has been shown to be a very strong signal to indicate that you can stop your antibiotics. Now, use of PCT is not as simple as it may sound, and there are several pitfalls. So first of all, I think it's important to realize that PCT cutoff ranges depend on the clinical setting. So it's a difference if you're in primary care or in a septic patient in the ICU. We also have to realize that all sepsis markers we have today, including PCT, are not perfect markers, and we have false positives and false negatives that occur. So in a patient after a surgical procedure, you will find an increase in PCT just due to the stress of surgery. So you have to really combine your clinical knowledge, your clinical assessment of the patient with PCT. Otherwise, you will not be able to use this marker efficiently. And also importantly, a single measurement of PCT is of limited value, and we should always use this marker, particularly for the sepsis population, as a monitoring marker. So last, I think, although there is important trials for sepsis, we need to conduct further studies because there are several infections which have not been well studied, such as endocarditis or pancreatitis or other types of infections. And so I think in the near future, we will learn much more how to use PCT efficiently in these different types of infection. Today, really for the respiratory tract and for the septic patient in the ICU, we have strong data, but we need to do further research to better understand how we use this biomarker efficiently. And with that, I would like to close, and I'd be happy to answer any questions you may have. Thank you very much.
Philip, thank you very much, especially for your very clear presentation. You gave to us very clear messages. I would like to ask one question. If we want to follow up those patients, septic patients, for prognosis or for antibiotic decisions, how frequently we should measure PCT levels?
So I think usually you can measure PCT every 24 or 48 hours. So usually in the normal medical ward, we recommend to measure PCT every 48 hours. I think in the critical care setting in an ICU patient, measurement every day or every other day is a good frequency to have a good readout of the marker. And to really give you feedback if a patient is in trouble or you need to change his therapeutic management.
Okay. Another question. How can we use PCT levels for viral or parasitic infections?
So I think there is a lot of studies comparing viral infection to bacterial infection. So let's say you have a patient coming in with a clinical syndrome of pneumonia, and there is influenza season. So you would expect it could also be an influenza viral infection or a typical bacterial infection. So if this patient comes into the ICU and his PCT level is very low, so let's say below 0.5, I think the viral infection becomes much more likely. And so for this patient, you really should do the viral testing and you should consider, antiviral therapy. If the same patient, has a very high PCT, it makes viral infection less likely and it argues more for a typical bacterial infection. Also, I think for the viral infected patients, you always have the issue of bacterial superinfection. So studies have also shown that if you have a viral influenza, let's say, but a bacterial superinfection, you will find that PCT in these patients go up much higher. So I think it is also helpful because we don't have really gold standard for bacterial or viral infection in these patients. But I think PCT can be another piece in the puzzle of these complex patients and point us to one or the other direction.
Okay. There's a comment from audiences. The PCT measurement may be so costly for low-income countries. It's good to shorten the antibiotic treatment, but we can't use it. This is just a comment.
Well, I think it's an important comment, and costs are a big issue. So there have been several cost analysis studies, and I think when you talk about costs, you have to look at the overall equation. So of course you have costs for your marker PCT or other diagnostic tools you use, but then you have also potential savings, which are antibiotics, which are very expensive in the ICU. And you have other savings, such as less resistance of antibiotics in your population. And so I think, in the end, you have to do the overall calculations. I think as long as you use PCT and you act upon your level, so you actually use your level for clinical decision-making and you have therapeutic consequences, then I think it's well invested money. If you just measure PCT in a patient just to see the level, but you don't change anything in your patient, then I agree, then it's just an expensive marker that doesn't have any benefit. And this is why I would only recommend the use of PCT really in clinical protocols and to have your physicians educated so they will act upon the levels and you will have these positive findings that were demonstrated in the clinical trials. But I think it's an important comment, and costs are more and more an issue, in the different healthcare systems.
Then in terms of this, should put pressure on hospital managers to use PCT measurement just to decrease antibiotic cost. This is the way, I think.
Yes, I think in many hospitals you have different budgets. So you have the pharmacy budget, which concerns about it's concerned about the antibiotic, and then you have the lab budget, which is concerned about the diagnostic markers. And so if you use PCT or other diagnostic markers, you will have more costs in the lab, and you have some gains, in the pharmacy. And so I think these two, departments have to speak to each other and really see the overall benefit for the system and not so much only for their own department. But it's a complex discussion, of course.
Okay, thank you very much, Philip. Very clear presentation and very clear answer. And
thank you very much.
We are switching to our seventh speaker of the session, Dr. Michael Bauer from Vienna University, from Germany. He's professor of anesthesiology and critical care and chief executive director of Center for Sepsis Control Care at Vienna University Hospitals. Dr. Bauer's interest is the field of molecular mechanisms and system biology of sepsis and shock-related organ dysfunctions. His topic is novel and emerging diagnostic. Dr. Bauer, it's your turn, please.
Thank you, Dr. Unal. And I guess I can just stop where Philip Schuetz stopped. And now we are moving from the host side and the biomarkers to the diagnostics of the underlying infection. And despite all the critique we heard tonight from Flavia about sepsis 3 definition, I guess we are still on the same payroll with respect to the significance of sepsis as the infection as the triggering event of sepsis. So there's a big need to identify early the causative pathogens that trigger organ dysfunction in the septic host. And what Sepsis 3 also offers is an interesting conceptual framework to understand and perhaps better assess the interaction of pre-existing organ dysfunction and its deterioration by, for instance, developing nosocomial infection. And I guess here we still have, even when we abandon the CS concept, we have a significant diagnostic uncertainty whether the systemic inflammatory response we observe in these patients is triggered by this newly developing infection or not. And on the other hand side, we have this desperate need to cover the triggering infection appropriately with antibiotics, as inappropriate therapy or lack to achieve source control is associated with deterioration and poorer outcome in these patients. And as we are all painfully aware, this inappropriate therapy, primarily in nowadays ICUs, results from the crisis of multi-resistant bacteria. And there are even concerns that we are more and more frequently confronted with very difficult to treat bacteria. And as a flip side, we use very liberally in these life-threatening infections very potent antibiotics. And this should, at least in the best of all worlds, decrease this liberal use by better or improved diagnostics. And we are all also painfully aware that blood culture as the gold standard to identify pathogens in sepsis is theoretically highly sensitive, as it can pick up very few pathogens in a 10 milliliter sample, but it is restricted to metabolic active bacteria, and there are a lot of problems associated with blood culture, such as that they may be falsely negative if a concurrent antibiotic therapy is initiated, or if they are fastidious or difficult to culture bacteria. And I guess what is really the major limitation is the time requirement of up to several days and the overall low detection rate in the range of 10 to 20%. Furthermore, and perhaps reflecting the clinically limited information you can get from blood culture, intensivists are not particularly careful about getting these blood cultures collected. They don't really pay too much attention, and this is reflected in the perception from microbiologists that report on long transportation times, low number of incoming sets, and many false positives due to a lack of careful conducting of blood culture in the clinical routine. So this has prompted the need and the search for alternatives, and several molecular techniques or alternative molecular tests are currently discussed. And I would first start with the measurement of pathogen-associated molecular patterns as an alternative. For instance, what is a particular prominent problem is the detection of Candida albicans in critically ill patients, and the use of biomarkers such as 1,3-beta-D-glucane or Mannan and anti-Mannan antibodies has been recommended. In the latest version, it's no longer in of the Surviving Sepsis campaign, but this is primarily reflecting observation that many groups have made, and I show here, for example, data that we obtained in patients that underwent cardiac surgery involving cardiopulmonary bypass, and these patients have frequently very high levels of beta-glucan, which may really limit its use in surgical ICUs. On the other hand side, molecular tests based on the principle of PCR are really having a very big potential to improve diagnostics, and I would like to introduce a couple of these tests and also think about a bit the potential of PCR. So if you amplify nucleic acids from pathogens, you can significantly cut down the time requirements compared to culture-based assays. And if you look, for instance, at the performance of these tests and, for instance, compare it to the procalcitonin that has been just broadly discussed by Philip Schuetz, you can see that there is an association not only with the positivity of the blood culture, but also of the PCR. And the same holds true for C-reactive protein. There is an association with the positive PCR amplicon. And what is also important on the right-hand side, you can see here in real life, we assessed on our ward how long it takes until we get a culture or a PCR result to the ward. And if you look, for instance, at the time required to get 50% of the results back, it's in the range of 70 hours for culture, but only in the range of 21 hours for PCR in real life, with limited access, for instance, to technicians to take care of these samples at night, for instance. So when and how can PCR help to improve diagnostic performance in the clinical context? I guess this is taken here from a meta-analysis we conducted some 3 or 4 years ago. And you can see there is a higher rate of positivity for PCR, overall 1.5 times as many positive results compared to the conventional blood culture, but the concordance between the blood culture and the PCR also the concordance with other isolates from conventional microbiology is in the range of 80%. So approximately 80% of culture results can be predicted early on by a PCR amplicon. So if you just break it down to receiver operating curves, this essentially indicates that PCR can serve to rule in sepsis in a low pretest probability population, and this holds true for overall septic patients, but as well if you look differentially at bacteria or fungal amplicons. So there are currently a lot of very interesting developments in the technical performance of these kits so that they can be performed with very limited hands-on time compared to previous attempts. And this is, for instance, shown here for the film array. So essentially, many of these test systems rely on cartouches that are very easy to handle and can be easily used in the clinical context to get very rapid results. And I picked here just as an example a panel for meningitis and encephalitis. So if you have a target population of suspected CNS infection, for instance, in the emergency department or in pediatrics, you not only get a rapid result for bacteria, which is really new, you get also typical associated viruses such as CMV or herpes virus family, or even fungi such as Cryptococcus neoformans. So this is really a quantum leap compared to conventional diagnostics. And looking at these panels, they are popping up, and each and every year there are new panels. And once again, here in the context what we discussed on the use of antibiotics and PCT to help with stewardship for respiratory infections. If you look here at the PCR respiratory panels, you also see that along with the typical bacterial pathogens, you also get information on viruses, which makes it a lot more reasonable to, for instance, withhold antibiotics in patients. And in our hands, we currently use these panels, for instance, in the immunocompromised post, for instance, patients that have been on the ICU for a prolonged period of time, or in hemato-oncology patients. And as I already made the point, these are promising techniques, and they are coming now and are more easily available, although there are still data lacking regarding the clinical utility. But in the light of the current multi-resistance problems, I guess it's about time to subject them to clinical utility testing. So there are potential alternatives. It's always the key issue. Can they pick up resistance, in particular for multi-resistant gram-negative pathogens? I won't talk today about next-generation sequencing, as this is restricted really to the genes, and this not necessarily reflects the phenotype. There is some interesting development in the field, for instance, of mass spectrometry, but also with respect to a substantially improved phenotypic characterization, combining molecular and conventional culture approaches. And these are the techniques that I would like to address. It's a pity that the Eurydica system, which had been introduced by Abbott, is no longer available. It's still in its infancy. It's technically very demanding, but the potential of this PCR, essentially PCR-based technology, is great because it potentially also holds promise to identify resistance genes in addition to just characterization of the underlying pathogen. And this has been tested in Europe, for instance, by a clinical study addressing rapid diagnosis of infection in the critically ill. And essentially, this showed that independent arbitrators suggested that these techniques can potentially result in altered treatment in even more than half of the patients, and it's also confirming that the rate of positive results increases with these techniques. So last but not least, I would like to address the phenotypic characterization, the so-called accelerate system. Essentially, what this system does is to identify pathogens on a single cell level by fluorescence in situ hybridization, and also assessing the phenotypic resistance using morphokinetics on a single cell level. So you can get very important information about resistance. It's still an expensive technique. It requires molecular biology and sophisticated handling, but it offers currently the best potential information to really identify phenotypic resistance in isolated pathogens, and this in a very rapid fashion. This may even be in the future be also achieved or improved by other light-based techniques. It's also similar, feasible to use spectroscopy, for instance, to identify pathogens. And just this is taken from the group of Ute Neugebauer. She has really achieved a direct assessment, for instance, of a pathogen from a urinary sample with these light-based techniques within 35 minutes by just identifying individual bacteria, once again on a single cell level. And you can, with the same technique, in approximately 2 hours, also using microfluidic supported administration of antibiotics, for instance, assess also phenotypic resistance, in this case against vancomycin, for instance, in E. faecalis. So this can be introduced as a practical test within the next couple of years, and there are many of these techniques right now evolving. So to summarize the potential of conventional, and in particular the combination of conventional with molecular techniques, we can yield more positive results with these approaches, and we can reduce the time to result dramatically. And what is even more important in the light of the resistance crisis, these techniques are right now at least principally able to provide substantially more information regarding resistance in the early time frame of the first hours or the first day after life-threatening infection develops, and they are all ready to be used, and they warrant prospective testing regarding their clinical utility. And I would like to finish with this statement that is meanwhile 20 years old, but it still holds true, from Roger Bone. We should spend more time to achieve an accurate diagnosis and less time for searching a magic bullet. Thank you for your attention.
Dr. Bauer, thank you very much. Very interesting presentation, and you are showing us our future. There are some questions from audiences. What kind of samples are you using for testing? Blood, aspirates of respiratory systems, also tissue samples. Is it possible to use some of them?
Yes, actually, these molecular techniques, due to the time restrictions, I focus primarily on blood-based tests, but these techniques are also available for instance, bronchoalveolar lavage, but also for tissue samples. And this may be very important in difficult to treat infections such as implant associated infections, or once again fastidious and difficult to culture pathogens. So there is a big promise, at least, of these techniques, and they are currently also evaluated beyond the use of blood samples, primarily for respiratory samples and osteocutaneous specimen in orthopedic infections.
Okay.
But also endocarditis.
Yeah. Also, sorry.
Also endocarditis, for instance, to give a practical example.
Okay. If we diagnose with these techniques infections, microorganisms, and decide to use or correct antibiotics within hours, even in minutes, no value of cost of these techniques, these new diagnostic techniques. However, I wanted to know the cost of these techniques for each sample.
Yeah, actually, this is very difficult to answer. So I would say that some of these molecular techniques that require sophisticated molecular probes, such as fluorescence in situ hybridization, you are in the range of 150 euros per sample. But the light-based techniques, so if you use, for instance, spectroscopy, and that's the need or the really interesting aspect of these techniques, they will be very cheap per sample, because you don't require, except for laser equipment, you don't require like antibodies or hybridization reagents. So this holds a great promise if these techniques can be developed, and I'm very confident that this is going to happen. The related costs per sample are low.
I see. There's one more question, but I couldn't explain it very well because I'm not microbiologist. The question is how to decrease cost of PCR-based techniques for LMIC, minimal inhibitory concentration. Do you have any answer for this question? Yes.
Yeah, actually, I'm a microbiologist neither. I'm a intensive care physician, so I can't answer really this technical question. But right now, MIC is from the techniques that I presented, as far as I know, only achievable with phenotypic characterization, for instance, as shown here for the accelerate system. So I'm not aware that currently in a clinically available test you can assess with PCR MICs. I'm not aware of that.
Same like me. Okay, Dr. Bauer, thank you very much for your presentation. Now we are switching to our last speaker, Professor Richard Hotchkiss from Washington University, United States. He is professor in anesthesiology, medicine, surgery, molecular biology, and pharmacology, and has board certification on anesthesiology, critical care anesthesia, and internal medicine. He has served as president of the Shock Society and has served on several NIH study sections, including as a permanent member of the NIH Surgery, Anesthesiology, Trauma Study section. The focus of the Hotchkiss lab is defining new methods for the treatment of sepsis. He is international known for his seminal research explaining the role of lymphocyte programmed cell death as an underlying cause of sepsis. His topic of speech is novel and emerging treatments. Dr. Hotchkiss, please, it's your turn.
Thank you very much. It's an honor to be speaking at this great forum. So I would like to acknowledge my research funding from the National Institutes of Health, Bristol Myers Squibb, and GlaxoSmithKline, and we are doing 2 clinical trials. So to begin, what I want in this brief presentation is an overview, take-home messages that there are new findings which reveal a key role for immunosuppression and sepsis, and because of that, it builds a case for use of these new drugs which boost the immune system. I'm going to talk briefly about some of the current immunotherapy trials and give you a vision into the future. So the traditional theory about the pathogenesis of sepsis was that sepsis was due to a overabundant, overexuberant, hyperinflammatory response consisting of fever, shock, and organ failure, and that this was what led to death. This prevailing concept of uncontrolled systemic inflammation was dominant for many years. This made sense because when they did animal models of endotoxin, where they injected endotoxin or live bacteria, there was a very fulminant course, and when they discovered tumor necrosis factor, TNF, and other pro-inflammatory cytokines, they were markedly elevated in these endotoxin bacterial models, and you could prevent death by blocking inflammation and cytokines. So there were over 50 trials of various agents which blocked inflammation or blocked these inflammatory cytokines. When all of these have failed to date, this led investigators and physicians to go back and really study what is going on. Are we barking up the wrong tree? There's a kind of a nice saying about just because the path is well trodden does not mean you're heading in the right direction. So a new paradigm, which I'm going to present here, is that both pro and anti-inflammatory responses occur early and simultaneously in sepsis. Relative immunosuppression, which involves both the innate and the adaptive arms of the immune system, can occur soon after sepsis begins, and that immunity, depressed immune function, can be persistent for weeks or months after sepsis. Patients with this immune suppression may die due to their failure to eradicate the organisms, the bacteria that cause the primary infection, or a lot of patients that are in the ICU develop these new secondary infections. They get hospital-acquired infections, which ultimately leads to death. So what the new paradigm is that both pro and anti-inflammatory processes occur on the early phase of sepsis. And yes, some patients can die in the early hyperinflammatory phase of sepsis. We take care of these patients in the ICU, and the patients come in fulminant shock. But we've gotten much better at keeping these patients alive. And the patients now progress usually into this more chronic phase of this immune suppression, where they've lost a lot of their ability to eradicate the infections. There's a great deal of death of the lymphocytes, the white blood cells that are very important in fighting infection. There's an increase in these suppressor cells, that T regulatory cells and myeloid-derived suppressor cells, which impair the host ability to fight infection. So what we will see is, what we will hope to see is ways to restore, to boost the patient's immunity. we can learn a lot about how to boost immunity in sepsis by looking at what's going on now in cancer, in oncology. Immunotherapy is now the most exciting area in treatment of patients with cancer. They previously had felt that immunotherapy would not work in cancer, but recent developments with the discovery of these new mechanisms of immune suppression have really opened up new approaches to cancer, and it's one of the most, it's been startling in how effective it's been in improving survival in patients with multiple different types of tumors. What is really particularly interesting is that there are many similarities in the depressed immune system in patients with cancer and in patients with sepsis. They overlap. They share many of the immunosuppressive mechanisms. This is felt to be due to the fact that both conditions, there's chronic inflammation and persistent antigen exposure. So we are learning that some of the drugs that are being used, here are the list of 5 drugs that are now in trials in patients with sepsis to boost immunity. These same drugs, GM-CSF, thymosin 1-alpha, interleukin 7, and anti-PD-1 and PD-L1, are now in trials both in sepsis and in cancer. Several of them have already been approved for cancer. Now, the vision into the future, immunotherapy. I believe, as Dr. Bauer has alluded to before, that biomarkers will help us profile the immune status of septic patients, that we will then be able to treat them based upon their various phases in their immune system, and that we should be able to improve morbidity and mortality. This one remarkable case of a patient I'll briefly describe shows the power of immunotherapy in sepsis. This was a case of a 30-year-old female who was a victim of that Brussels terrorist attack in March 2016. She had sustained major injuries of the pelvis, femur fractures. She had a lot of soft tissue damage and pulmonary contusion. In fact, she arrested in the emergency room. Her hospital course, she was resuscitated in the emergency room. Her hospital course was complicated by sepsis, by infection of the bone, osteomyelitis, and she developed multi-drug resistant organisms of Enterobacteriaceae and this fungal infection with mucor. Despite being treated with very potent antifungal agents, they were unable to contain the mucor infection. It was invading into the abdominal organs, and surgery was tried. She had her stomach removed and the spleen removed, but the infection was involving the blood vessels. The doctors there did immune phenotyping. That is, they determined what parts of her immune system were impaired, and they gave treatment with these new immunotherapy, nivolumab, anti-PD-1, and interferon gamma. It was begun on a compassionate basis. This patient, who was going to die because of this fungal infection that was uncontrolled, slowly improved. She had resolution of the sepsis. Repeat CT scan showed no evidence of the tumor, and she was discharged from the hospital 80 days later. So, in conclusion, sepsis evolves into an immunosuppressive condition with poor clinical outcomes. Immunologic defects in sepsis are very similar to those occurring in cancer and suggest a common mechanism or mechanisms. Immunotherapy is offering great hope in cancer patients, and we speculate it will also do so in sepsis. And interventions with the potential to improve host immune function are being studied. And that's the end of my presentation. I'm happy to take any questions.
Thank you very much for your presentation.
Oh, okay.
It's a very difficult subject for us, for clinicians, but I think there's a long way to find correct and combined immunotherapeutic approach for the therapy of the treatment of the sepsis. But at least we can possibly explain in more detail the mechanisms with your studies. I would like to ask a question. How can we add microbiome theory to your results?
Add which theory to my results?
Microbiome. The flora, enteral flora of the...
Oh, yeah, microbiome.
Yes.
Yes, that's a great question. What investigators have found out is that the microbiome, the bacteria in the intestine, interact with immune cells in the intestine. The intestine is the organ that has the largest number of immune cells, lymphocytes and dendritic cells, things. And that bacteria provide feedback and shape the immune response such that if you have a different type of bacteria, there have been several studies on this, the animals will respond. Their cancer, these are cancer trials, their cancer will respond to a certain type of immunotherapy. But if mice which don't respond to that immunotherapy, if you change their microbiome, they now will respond to that immunotherapy. So it is, you're exactly correct, that the microbiome helps shape the immune response. And in sepsis, what's very important is that there's loss by programmed cell death of billions of the immune cells, the lymphocytes and dendritic cells in the intestine, in the gastrointestinal associated lymphoid tissues. This is very similar to what occurs in HIV patients. So the microbiome is critical in that. And we may manipulate the microbiome. I know the oncology groups are looking at that to manipulate the microbiome in the cancer patients to make their drugs work better.
Okay, there is one question from audiences. What do you think about sepsis observer systems?
Sepsis observer systems?
Extracorporeal observer systems.
Yeah.
Absorption.
Yes. So I would say the jury is still out on that. Some fairly significant trials. I believe Didier Payen published a paper on this where it really failed that endotoxin removal or cytokine removal was not effective in improving outcome. Now they may be able to change these filters that they're using, but I think at this time there is really no definitive evidence that they are effective in sepsis.
Okay, there's one more question from audiences. Classically, we know that steroids have immunosuppressive effects. How can we use them during sepsis?
Yes, and I think that there have been some remarkable discussion of the therapies with thiamine, vitamin C, and corticosteroids, and in that chest article. I would say that there's probably a subset of septic patients that are in this hyperinflammatory phase that may benefit from a very short course of steroids. We know that you'd have to use low doses of steroids. Somewhere in the critical care medicine, the Society of Critical Care Medicine recommendation is 200 milligrams of hydrocortisone a day for 5 days, no longer. I think in some of those patients it may work to improve outcome. We're going to know soon based upon the very large trial that's being conducted in Australia and New Zealand. It's called the Adrenal Trial, and that data should be available within the next few months. Personally, I don't think I think that you must be very careful to keep your dose of steroids low and your duration short, and not use it except in those patients that have the hyperinflammatory septic shock that's not responding, to fluids and vasopressors, and avoid it as much as you can. That's my thinking on it. Yeah.
Okay, thank you very much, Dr. Professor Hotchkiss. And now we are switching to discussion period. Other speakers are online now, and we can start to a short discussion period. And I know that some of the previous speakers have some questions. I am expecting to listen their questions, also comment. Michael, Harry, Philip, yes, and Tex should be on the line. And do you have any comment or any questions about this session, about the subjects of this session?
Actually, I would really like to ask Richard Hotchkiss, what would be the suitable biomarkers to go along with your interventions, for instance, with TBE intervention? What would you need to know about the immune status in order to really identify patients that would benefit from these interventions?
Yes, Michael, and you're doing a lot of the work to help identify that. I believe you're one of the leaders in this field, and I think that looking at gene expression is one way, and that's important, and that'll ultimately probably become the way. Personally, I believe that we need some functional test, rapid functional test of the lymphocytes for reflection of adaptive immunity, and I prefer interferon gamma production because that has been shown and is increasingly shown to be critical in controlling in oncology, that the drugs, the immunotherapeutics that are going to work act to increase T-cell interferon gamma production. And I believe that therapy, immune therapy in sepsis that's going to work is going to increase T-cell interferon gamma production. I think not only is interferon gamma have important actions to activate the innate immune system, but it's a measure, it's a reflection that the T cells are back working again. And the CD4 helper cells help control the infection. So I think personally a functional test of T cells making interferon gamma and monocytes making TNF alpha. If you had a rapid test for that, the functional test. Now, what I know a lot of people are looking at is they're trying to show, and when you do have an increase in interferon gamma, and then they're correlating gene expression to say these genes predict that they're going to make the patient's T cells are coming online. So I'll finish right here. What you'll do is you'll have a patient that you're thinking about treating with like anti-PD-1 or IL-7. You'll look at when you take their T cells and you stimulate them, say ex vivo, and add anti-PD-1 or IL-7, do they restore their function? That patient's going to be a good candidate for immunotherapy. And hopefully your gene therapy and things, your gene expression data will then be used to replace it so we don't have to do the functional test.
Okay, there is a question for Dr. Bauer. One of the audiences asking that can we use these new techniques at low and middle income countries at extreme conditions like very hot weather or paucity in electricity?
Yeah, actually, I would like to really comment on that. First of all, there are techniques available, for instance, that are supported by the Bill Gates Foundation to bring these very simple PCR-based techniques to low and middle income countries. And all the evolving concepts that I have shown using biophotonics, like spectroscopy, things like that, are essentially very low costs are associated with these tests. So this is right now a rapidly evolving field, what you can do, and the prices are going down, the techniques are getting available, and it's we are right now at the point where these techniques are set up in a way that they are one world suitable, so they can be used at night in the ICU in Europe or the US, as well as in low and middle income countries, because they do not require sophisticated support. They don't need a lot of hands-on time or trained personnel, so they are getting easier and less expensive per sample.
Okay, thank you very much. There is a question from the audience. Can we use 0.5 PCT level as a cutoff value in pregnant patients?
Would you repeat the last part of the question? Excuse me.
Can we use 0.5 PCT level as a cutoff value for pregnant patients?
For pregnant patients?
Pregnant patients, yes.
Oh.
Difficult question, huh?
I don't know who wants to answer that one.
I don't think we know. I don't think there's data for that.
Yeah. I think the pregnant women actually are not, included in many of the trials. So honestly, I don't know. I have not much experience with this patient population.
Yeah.
Okay.
On that, this is Jean-Paul Souza from WHO, and I just want to make a comment. Thank you.
Yes, please.
Yes, I think this spotlight on maternal and neonatal sepsis, I think this question was very interesting because it highlights an important issue, the fact that there are certain populations that are not really addressed by many of the studies that are currently ongoing, particularly if we think about the development of the definition of the sepsis 3 definition that did not consider or actively excluded pregnant women from the databases. I think just to highlight the importance of further research and attention to specific groups, including pregnant women. In this case, pregnant women, they have about 100,000 maternal deaths that are related to sepsis every year around the world, and it's clearly an area where we don't normally focus our attention or research efforts.
Yes.
Okay.
Yeah. Any comment?
Hi. This is
I just wanted to say I agree with your comment, and I think it's very important that we really gather more clinical data for this particular vulnerable patient population, because we are very hesitant with these patients, but we shouldn't be, and we should be more active in involving them in trials, because otherwise we'll never understand the best care for these patients. I agree.
This is Tex Kassoon from the GSA, and what I'd like to do, we're coming to the end of the conference. I'd like to thank the audience for sticking with us all day. I'd also like to thank the speakers and the chairs and everyone who's made this possible, including our sponsors. This is just the start of a project, as we know, and I'd like to encourage everyone to participate in World Sepsis Day tomorrow and in the WHO campaign and the point prevalence study. I think from reflection from me, this is a continuation of quite a journey started in 2010 to the present day when we've gotten the New Year resolution. I hope that over the next little while we develop new partnerships and we continue the process, as João Paulo said, to look at tackling some of the more difficult questions as it pertains to maternal and newborn sepsis. We know it's going to be difficult, but on reflection, I thought about the quotation of President Kennedy when he chose to go to the moon, and he said, he chose not because it is easy, but because it is hard, and because that goal will serve to organize and measure the best of our energies and skills. And I think ultimately, or the best of our energies and skills will translate to better outcomes for patients and families. So I'd like to thank everyone and have a very good Sepsis Day, World Sepsis Day tomorrow, and hopefully we can continue on this journey. Thank you.
Oh, thank you. Okay. Thank you very much. I'm as a chair, I should say thank you to all speakers before closing the session, because in a very limited time, they gave us very important, understandable, guiding information. I also want to present my graduate participants. They have followed us 2.5 hours. It was very long session. Dear my colleagues, we should be unit our powers in order to become more powerful and successful in this war against sepsis. Please visit our Global Sepsis Alliance webpage and World Sepsis Day websites. And please follow us on Facebook, Twitter, and Instagram. Also, please sign the World Sepsis Declaration. Also, I would like to say thank and to present our graduate to all of our sponsors who have enabled to organize this kind of web meetings and ensure the continuity of Global Sepsis Alliance and World Sepsis Day. Thanks a lot to everybody, and see you at next organization. Have a good day, good evening, good morning, good afternoon for everybody.
Thank you.
And before we close, on behalf of the World Health Organization and the Global Sepsis Alliance, I would like to thank once more the audience. We had today over 7,300 participants from more than 140 countries. A big thank you from WHO to the speakers and chairs that participated from around the world. Special thanks to everybody that made this possible, particularly Marvin Vick, the Global Sepsis Alliance, the several institutions, organizations, and funders that have supported this event and are supporting the Global Maternal and Neonatal Sepsis initiative. And as a take-home message, I'd like to please for the audience to bear in mind that sepsis is a condition that is associated with over 6 million deaths every year, including 1 million neonates and around 100,000 maternal deaths. Want to emphasize that there is a new WHO definition on maternal sepsis, and there is a big study being conducted in 54 countries to test and further develop this definition. And once again, encourage everybody to participate in the World Sepsis Day tomorrow, be it online or at local events in different countries around the world. And once again, to sign the World Sepsis Declaration, and invite you to engage on the social media, Facebook, Twitter, and Instagram. All the talks will be soon available at YouTube and an Apple podcast. So stay tuned to the Congress website for a release schedule. You may also receive some information from WHO on your email address concerning this and other activities. And to finalize, I just want to wish everyone a good end of the day for everyone and a good activity for tomorrow. Thank you.